Behavioral and psychiatric emergencies and suicide. So this big umbrella, behavioral, psychiatric emergencies, covers a whole lot. It may be something that is an actual psychiatric condition. It may be some sort of external factor, drugs, alcohol, trauma, stress, something going on around them. It really depends. There's a lot of stuff that's under this overall umbrella. So what is a behavioral emergency? Behavior is the manner in which a person acts or performs. A behavioral emergency is identified as abnormal behavior for a specific situation that is unacceptable or intolerable to the patient, their family, or the community. This is not just somebody being a little bit weird, like in their backyard. This is somebody not being able to function in a very basic way with their family, with society, something like that. It's truly affecting their life or their lifestyle or the lives of people around them. Behavioral patients may appear confused. They may have altered mental status. There may be a lot that's going on. So they've got a psychiatric condition. A lot of the common ones that you'll see are some sort of anxiety disorder, some sort of panic, nervousness type thing. You'll see depression. You'll see a lot of bipolar disorder, or manic depressive it used to be called. You'll see some schizophrenia. There's several places, actually there's quite a few places in the Dallas area. Did anybody get to go to Terrell State Hospital last year out of this group? May have been the other two schools. They went out to Terrell State, and they've got quite a few patients ranging between depression, bipolar, and schizophrenia. Those kids got to actually talk to a schizophrenic patient and kind of get to see how their mind works. It's really interesting. So, unfortunately, I didn't get to do that. Physical causes of behavioral emergencies, and that's not always psychiatric. Sometimes these other physical causes can be just as life-threatening. They may actually be more important. So this picture, you can kind of see it up there. We're looking at things like hyperthermia. So some sort of temperature issue with the body, with the brain, is going to cause people to behave weird. Hyperglycemia can also cause an issue, altered mental status. Hypoxia, meaning not enough oxygen. Somebody's had a stroke, head trauma, if they're substance abuse, alcohol abuse. All of these are physical external causes that could result in a behavioral emergency. Normal reactions to a stressful situation produce emotions, fear, anger, sorrow, excitability, grief, all different things that people may feel. If people are just stressed about a situation, your job is basically to keep them calm and keep them safe. So keep your own emotions under control. Don't react to what they're saying or what they're doing. Listen to them. Be honest. Try to help calm them down and tell them, I'm here to help you. I want to help you. What can I do? But be very alert for any changes in their behavior that may occur. Notice if they start to, if their emotions change or they become more aggressive in their actions or something like that. If something changes for the worse, you're going to need help. It's not just going to be about you at that point. So, if a patient has some sort of behavioral or psychiatric emergency happening, it's going to look a bunch of different ways, or it could look a bunch of different ways. They may be very withdrawn, not communicating with anybody, even to the point of seeming catatonic. They may be very talkative, very agitated, very aggressive in what they're doing. They may be threatening to harm themselves or other people. They may just be very bizarre. They may present like they're crazy or talking to people who aren't there. There's a whole lot of stuff that you could see. In general, identify yourself. Speak slowly, clearly. Try to keep them calm. Try to listen to them. Keep your body language positive. Don't get too close to them for their safety as well as yours. For one thing, it's going to make them much more agitated in general or much more uncomfortable if you get really up close to their space. For another, if their moods do change suddenly and they become aggressive or something like that, you don't want to be within arm's reach. You want to keep yourself safe as well. Again, be alert for those changes in their behavior that could cause a real problem, or that could be signs of a real problem. When you're interacting with a patient in one of these situations, be very careful with your scene size up. You don't want to rush in and assume that it's safe unless you really know for sure. I mean, if you've got a patient who's schizophrenic and they have some sort of implement near them that could be potentially used to hurt you. You want to be really careful before getting very close to them. If they do become more aggressive or somehow see you as a threat, and you haven't checked your scene first, you could be in trouble. Identify yourself again, speak very clearly to them, and then start doing your assessment. Same primary assessment as normal, same physical exam that you pretty much always do. Try to get as good of a history as possible. A lot of these patients, especially if they're psychiatric, are not going to be able to give you a super clear history themselves. Sometimes they do. Sometimes they've got a really good memory for every doctor they've ever seen and every medication they've ever taken, and they want to tell you each individual story of everything that has happened to them medically over the past 20 years. Sometimes these patients deny that they ever have taken medication or that there's anything wrong with them, and they think that you should just go away. So get as thorough of a history as you can. Try to talk to, if the patient's doctor or family member or something is nearby, try to get as much information as possible in whatever way you need to get it. Some things you might see in a patient who's having a behavioral or psychiatric emergency. Panic, anxiety, we talked about those. Unusual appearance, if they're not truly focused in on this world and everything that's happening around them, they may not care about things like brushing their hair or something like that. You're probably going to see agitation, unusual activity, unusual speech patterns, whether that's that they're slurring their words or not talking clearly or repeating words. There's a lot of different ways that could come out. Self-destructive behavior, again, wanting to harm themselves or others, and violence, aggressive behavior in general. You may see these things. Suicide. Suicide is the 8th leading cause of death overall in the U.S. For 15 to 24-year-olds, it is the 3rd leading cause of death. It's actually got rising numbers in the geriatric population as well, which means elderly patients. Factors that go into suicide. These are just some of them. Substance abuse, depression or other psychiatric issues, age, stress levels, recent emotional trauma, something like that. If you have a patient who is threatening suicide or seems suicidal, it's very important for you to interact with them as carefully as possible. Don't try to argue with them. Don't threaten them or try to make it seem like you're going to stop them from doing whatever it is that they want to do. Keep yourself safe first of all. Try to talk to them. Try to get their history, physical exam, if it's safe to get that close. Reassess them. But if they're suicidal, again, you don't want to interfere. You don't want to get in their way and potentially cause a problem for yourself. If you have a patient who is aggressive or is hostile, make sure that you make yourself as non-threatening as possible. Make sure they don't see you as a threat or they don't see you as somebody who's going to stand in their way. Make sure that if something goes wrong, you can get out of there. If you have to, jump out of your ambulance, leave the crazy person inside to do whatever it is that they want to do and get yourself out and get safe. First priority. Stay alert for any sort of weapons or like I said, anything that they might have near them or on their body that they could use to hurt you with. Try to be as diligent as possible to the other people around you to help them stay safe as well, meaning talking to dispatch and letting them know what's happening, getting information from family and bystanders, trying to understand the full situation of what's happening. Again, make sure you're safe, keep the patient calm, try to do a thorough assessment if you can, restrain the patient, we say if necessary. Generally speaking, if it gets to this point, you need to have law enforcement on your side. It really shouldn't come down to you having to hold down a patient at any point. That's just not safe for them or for you. So when we talk about restraining or using reasonable force on a patient, reasonable force is the force necessary to keep the patient from injuring themselves or injuring other people. And reasonable varies based person to person. So a small, petite woman, she may be super aggressive, but a reasonable amount of force for her is not going to be the same amount of force for a 300-pound, 6-foot-tall man who's being equally aggressive. One of them I might try to help. The other one I would definitely run in the opposite direction from, because that's way above my pay grade in terms of trying to restrain them or anything like that. That's when I would call in law enforcement. You also want to be looking at the type of behavior they're exhibiting, whether they seem super aggressive or not, what their mental status seems to be, if they're kind of checked into what's going on, or if they're totally like off the deep end. And you also want to make sure that you have appropriate methods of restraint available, whatever that means. You know, your stretchers have straps, the backboards have straps. Those are useful. You may have other things on the ambulance that you can use, like the triangle bandages if you need to kind of help tie down a leg or something like that specifically to your backboard. But you're not going to have, say, the same kind of restraints that law enforcement does. So just be aware of your limitations as far as what you can even do. Make sure that you're not trying to restrain a patient all by yourself. If there's one way to get yourself hurt, it is go in swinging towards a patient all by yourself who doesn't care if they hurt you or not. Stay beyond their reach until you're actually ready to do something, and when it comes time, act quickly. Hopefully you'll have multiple people. It says 4 people, 1 at each limb, as well as ideally 1 person to talk to the patient and explain what's happening, try to continue to calm them down while their limbs are being restrained appropriately. And again, this is usually not something you will ever have to do. This is mostly law enforcement's job, if it gets to this point. Once the patient is restrained, you still have certain jobs that you have to do. You've got to be careful of their airway, got to be careful of their breathing. You don't want to restrain them in such a way that it's going to be hard for them to breathe. For one thing, that's not good for your patient. For another thing, from y'all's standpoint, it's a huge legal issue. If you restrain a patient where they couldn't breathe properly, oh man, you can get in so much trouble. So be smart about it. Make sure that when they're restrained, they are adequately restrained, that it's not just not just sort of tight. Make it as appropriately tight as it needs to be safe for the patient, keep their circulation and stuff going, but also to hold them in. Reassess that. Make sure that they're not moving free of their restraints. Also reassess for vital signs, circulation, breathing, things like that, to make sure that they're not being adversely affected by the way that you've restrained them down. And for sure, document thoroughly. You want to make sure restraining is not an ideal thing to happen for a patient. So you want to make sure that you've written down everything that happened, documented completely, again, just for your own safety, liability, legal side. You may see patients, let's see what the next couple slides are. It's a random slide to have in there, okay. Excited delirium is a specific name for a type of behavior that we see. Extremely agitated psychotic behavior, followed by a cessation of struggling, followed by respiratory arrest, followed by death. And this isn't something that just happens randomly to any patient. It's usually preceded by cocaine use. It's a specific pattern of behavior. They're usually going to be hyperthermic, meaning overheated body temperature, shouting incoherently, very agitated. Often a patient who's experiencing this excited delirium may have been a patient who was restrained improperly. That's what I was talking about. Make sure that they can breathe. Don't restrain them so tight across the chest that they can't actually breathe in and out properly. It's what they call positional asphyxia. And it's really dangerous. It's obviously dangerous for your patient. And if it was something that you caused to happen, you'd be in huge trouble as well. Medical legal considerations of restraint and dealing with psychiatric or behavioral emergency patients. You need to still try to get consent if possible. Remember, consent is supposed to be informed and expressed. If a patient is mentally incapable of making that decision, we talk about implied consent. And that's allowed. The law usually allows that we can transport patients against their will if they seem to be a danger to themselves or others. But it's usually going to require more authority than just you have. It's not your choice to make. We're talking medical control. We're talking law enforcement, things like that, to ensure that it's done properly and safely and legally as much as possible. Another thing to be careful of, sexual misconduct in these situations. Because of the physical closeness involved in restraining a patient, sometimes EMS providers can be accused of inappropriate touching or something like that. The best way to deal with this is basically to always have a third-party witness at all times. That doesn't just mean you and your partner are like witnesses for each other. That means If you've got a police officer who's standing there watching what you're doing, he's a great witness to tell, oh yes, I saw what they were doing and they were doing exactly what was appropriate to restrain this patient. If you've got that patient's doctor or nurse or sister or whatever, somebody nearby who can be watching, as many witnesses as possible are basically going to make sure that the patient can't come later and say that they were touched inappropriately in the process of being restrained. And that was it. Any questions on, we didn't really talk about specific emergencies, we just mostly talked about what you do to deal with them. Any questions about these topics? No? Nothing?
Where would you go if you had in the ambulance?
If I had a patient who was like being psychotic inside the ambulance, and I would get out and call my dispatcher.
What if they're like driving?
If we're like moving at the time, tell my partner to stop the ambulance. We both get out and call the dispatcher, and I would let that patient stay inside if they're a danger to me, let them stay inside the ambulance. That way, I mean, at the most, they can only hurt themselves or maybe some of the equipment.
What if they get out?
If they get out, keep yourself safe. I'm not going to run yelling after a patient with a syringe. Like, I mean, keep yourself safe is what it comes down to. If they're seriously threatening harm to you, or you don't feel like you can safely deal with that patient, just get away. Call your dispatcher, call law enforcement, whatever you need to do. In fact, definitely call your dispatcher and law enforcement. But yeah. Any other questions? Okay.